Diabetes mellitus, an overview. Type 1 diabetes usually affects children and people below 30 years of age, but can also affect older adults. Type 2 diabetes has also been known as non-insulin dependent diabetes mellitus, NIDM, or late onset diabetes. However, that term is no longer used because of confusion it may cause if patients were classified on the basis of treatment rather than pathogenesis. All types of diabetes including type 2 are diagnosed when fasting plasma glucose is more than 7 mmol/L on at least 2 occasions. Fasting is defined as no caloric intake for at least 8 hours, plus classic symptoms of diabetes, which include polyuria, polydipsia, and unexplained weight loss. Despite the volume of research that has been invested in diabetes research over past decades, the pathogenesis of type 1 diabetes is not fully understood but is thought to stem from multiple factors involving genetic abnormalities and/or environmental factors, leading to either a loss of insulin secretion or a decrease in insulin action. Several risk factors have been associated with the development of type 2 diabetes. Genetic factors in some ethnic groups, family history of diabetes, and increasing population age are examples of unmodifiable risk factors. Rising combinations of the aforementioned risk factors have contributed to the global epidemiology of both type 1 and type 2 diabetes. Type 2 diabetes is now one of the most common diseases in the world. The number of people with type 2 diabetes is increasing in every nation. The progressive nature of diabetes over time is associated with two types of long-term diabetes complications, macrovascular and microvascular. The major aim of diabetic care is to improve the quality of life of people with diabetes as well as to increase their life expectancy. Achievement of such an outcome is dependent on the provision of comprehensive, complementary and integrated health and social care across both primary and secondary settings through diabetes specialist professionals. Diabetes is a complex disease and its management requires addressing the prevention, early detection and management of complications as well as optimal control of hyperglycemia, hypertension, dyslipidemia, obesity and other CVD risk factors. The diabetes team is usually led by a medical diabetologist and in most cases includes diabetes specialist nurses, dietitians, podiatrists, and other collaborators such as ophthalmologists, nephrologists and pharmacists, in addition to services of care provided by the family medics. The main aspects of the national guideline for type 2 diabetes in the UK are summarised below. Structured education should be offered to people with type 2 diabetes and their carriers at the time of diagnosis. Newly diagnosed patients should have plasma glucose level monitored daily as part of self-education, with help in interpreting results. Support on setting targets for HbA1c levels, lipid levels and blood pressure should be given and HbA1c levels should be checked at least once every 6 months. Treatment aimed at lowering blood glucose. The main pharmacological treatments used to control hyperglycemia in type 2 diabetes are insulin and/or oral anti-diabetic agents, as illustrated in Appendix 1. Metformin should be offered as the first line of treatment if HbA1c is not reduced to target levels unless the patient has contraindications due to renal impairment or hypotension. Sulfonylurea should be used as a second line of treatment, and these treatments should be assessed by measuring HbA1c levels. A structured program should be employed when starting insulin by titrating blood glucose level with insulin concentration administered to establish the best dose for avoiding hypoglycemia. In case of patients already taking antihypertensive at diagnosis, blood pressure control and treatment should be reviewed. Advice on healthy lifestyle should be offered to people with blood pressure above 140/80ths of a millimeter of mercury or 130/80ths of a millimeter of mercury in people with kidney disease, cerebrovascular or eye damage surveillance should be offered. If blood pressure is not controlled, calcium channel blocker should be administered as the second or third line of treatment if target blood pressure is not achieved. Blood lipid control and cardiovascular risk management. Formal assessment of CVD risk is not required, as type 2 diabetes patients are already at premature risk of CVD. Increasing cholesterol-lowering treatment should be considered if the target cholesterol level is not achieved. Development of neuropathic symptoms should be assessed annually and findings discussed, including management and prognosis if any neuropathic symptoms are present. Clinical outcomes measured in diabetes care. A goal of diabetes management is to achieve better glycemic, blood pressure and lipid control. Glycemia is usually measured by A1C levels. It is considered a standard measure of blood sugar and glycemic control over the stated period. These may include patient-specific socio-demographic characteristics or disease-specific biological and clinical characteristics. Socio-demographic characteristics can be reflected by age, sex, marital status, educational level and ethnicity, while diabetes-related biological confounders can be recognized by evaluating the severity of the disease as a proxy. Diabetes complications can better be assessed by using information corresponding to the severity of disease progression, which can be identified from the amount and intensity of clinical symptoms, biomedical markers, organ complications and/or mortality. The severity was divided into 4 levels based on the intensity of care required: low, moderate, high and very high. Patients were stratified according to the severity of their illness in 6 clinical areas: glycemic control, CVD, peripheral vascular disease/peripheral neuropathy, eye disease, renal disease, and autonomic neuropathy. It was also constructed using large population of type 1 diabetes in primary care, which would be unsuitable for general use in clinical judgment. This index was successful to assess the effects of the health status of patients with diabetes on overall healthcare resource use and costs. The complications included retinopathy, nephropathy, neuropathy, cerebrovascular, cardiovascular, peripheral vascular disease and metabolic markers. The DCSI has been validated in American population, and it has been shown to perform better than using only the number of complications. In short, such diabetes severity indices can be used in randomized trials or for disease state management program to prove their costs benefits. Implementing NMP would have great impact on the outcomes of diabetes care in terms of the disease control or complication prevention.